introduction, and thank you for Dr. Qassas and Dr. Nermeen for inviting me to this very interesting conference. Today, my duty is to be talking about celiac disease, the management beyond the gluten-free diet. So I'm Ahmed Cordie, and we are talking about celiac disease, a small bowel disorder characterized by mucosal inflammation, villus atrophy, and crypt hyperplasia. And like an introduction, celiac disease occurs due to exposure to gluten, and it improves for sure after the withdrawal of gluten from diet. What is gluten? The gluten is a collective term for specific proteins. They are found in wheat, in rye, and in barley, and they are characterized by the high level of proline and glutamine. That's why they are not easily digested by the stomach and reach the intestine in indigested form. Here is the pathogenesis through the leaky junctions in the mucosa. It can find its way. This is induced by some viral infections, by microbiota dysbiosis, maybe due to some drugs, and some, or by the celiac disease itself. It finds its way to the lamina propria, and here it can be mediated by tissue transglutaminase to get more negative charges. So it can be presented by the antigen-presenting cells that harbor the HLA, DQ2, and DQ8 receptors to the gluten-specific T cells. Here we can activate the immune system, production of a lot of cytokines that can induce destruction of the epithelial cells, so it causes villus atrophy and the crypt hyperplasia. Also, it causes activation of the B cells to be producing antibodies against the tissue transglutaminase enzyme and against the deaminated gluten. This is my agenda for today, why we are talking about celiac disease in this meeting, and how to use an holistic approach for the celiac disease management. We are talking about celiac disease in this meeting, which is mainly focusing on the topics in hepatology and with great focus in the celiac liver disease. Firstly, we can ask ourselves, this is supposed to be a bulb with scanning through the QR code, but we can ask ourselves, how many patients do we have with celiac disease in our practice during the last months? How many patients with celiac disease have we screened for celiac disease over the last months? If you are not screening for something, we will not find it. So we need to find this out, to see this case presentation. She's a 43-year-old lady presented by 2 years history of persistently elevated transaminases. She had moderate fatigability, no diabetes, no hypertension, denied alcohol consumption. On examination, she had BMI of 22.5. All the specific causes for elevated transaminases have been excluded, including viral hepatitis, autoimmune hepatitis, primary biliary cholangitis, and Wilson disease, and abdominal ultrasound just showing elongated gallbladder. Here, laboratory investigations showed microcytic hypochromic anemia with elevated transaminases, normal alkaline phosphatase, normal thyroid functions, normal glycemic state, and normal lipid profile. So in absence of other causes, in your idea, the celiac disease can present in what percentage of patients who are presenting by elevated liver enzymes? Maybe 5%, 10%, 20%. Actually, according to the literature, 9% of the patients who are presenting by elevated liver enzymes without specific cause, it is due to celiac disease. And 40% of the patients with celiac disease, they might have elevated transaminases. And the liver dysfunction with celiac disease, it ranges from just asymptomatic rise in the transaminases. Maybe there is an autoimmune hepatitis, or there is primary biliary cholangitis, or primary sclerotic cholangitis. I will take you back to our case. The patient declared that he has intermittent bloating associated with diarrhea, and she was considering this irrelevant. When she was tested by the anti-TTG immunoglobulin A, it was elevated. Upper endoscopy was done with duodenal biopsy, and it showed there is increase in the intraepithelial lymphocytes, cryptal hyperplasia, without alteration in the villus texture. So we have MARCH2 in biopsy and elevated TTG. This is according to this complicated algorithm, may be diagnostic for celiac disease. So we need to keep in mind, if you are doing a workup for elevated transaminases, it is mandatory to be screening for hepatitis C, which have a prevalence of 0.04 nowadays, and for hepatitis B, which have a prevalence of 0.8 nowadays. Celiac disease have a prevalence in general population, 1.4 according to serology, and 0.8 according to the duodenal biopsies. Back to our case, 6 months later, after she has been on gluten-free diet, she had the enzymes normalized, and 12 months later, still the anti-TGG was normal, but the patient started to have elevated transaminases again. But she is getting obese, BMI changed to 25.5, abdominal ultrasound showing evidence of hepatic steatosis, and this was confirmed also by CAP. So we need to know that the persons who are living with celiac disease are subjected to the possibility, 3 times higher possibility for having muscle D, even after being adjusted for age and sex and other risk factors for muscle D. This is maybe due to the high intake of sugar and fats with the gluten-free diet, and maybe due to the pathogenesis with the increased intestinal permeability and translocation of toxins from the gut to the liver. Moreover, this patient also was diagnosed with osteoporosis. The T-score was minus 2.7 at this point to follow up. And that's why we need to be focusing on holistic approach for management. And this is the same you have heard yesterday about the management of muscle D. You need a holistic approach for management of muscle D. And this is not the only similarity. We have a lot of similarities between muscle D and celiac disease in this context. For example, the limitation for non-invasive testing, the need for the biopsy sometimes, the response variability and the monitoring, and the dietary interventions are the only approved way for the management. Still a lot of pharmacological therapies under development. And that's why we need to be addressing the holistic approach for celiac disease management. When it comes to this point, we need to highlight that the gluten-free diet on lifelong way, it is the main and only approved treatment for celiac disease. Now it can simply eliminate the antigenic trigger, so it can avoid the potential and can potentially revert the celiac specific alteration, so it can improve the clinical symptoms and for sure improve the quality of life of the person. But the celiac disease clinical management should include management of nutritional deficiencies, medication absorption, prevention of bone loss, vaccination, early detection and management of associated autoimmune conditions, and you need to pay attention for those who are non-responders. For the management of nutritional deficiencies, they are listed here in this slide. A lot of vitamins and minerals should be tested and managed according to the state of our patient. For the medication absorption, if the person is untreated or partially treated, there is risk for decline in the medication absorption, especially for something like the oral contraceptive pills, and that's why it should be avoided in the childbearing period ladies with celiac disease. For the prevention of bone loss, usually these persons have osteopenia, sometimes osteoporosis. It is due to the secondary hyperparathyroidism due to vitamin D deficiency. So we need to do regular monitoring by DEXA scans. It should be repeated every 1 year to be searching for the bone mineral density, and the treatment will be tailored according to gender and sex between vitamin D, calcium, and bisphosphonates according to the situation. For the vaccination, when you know that it ranges from 20% of uncomplicated celiac disease persons will be subjected to hyposplenism, and up to 80% of them, when they have complications, will have some sort of hyposplenism. So we need to be thinking about the vaccination for the pneumococcal vaccine and other capsulated organism. Also, we need to keep in mind that we have to do early detection and the management of the associated autoimmune conditions. We need to search for type 1 diabetes, for autoimmune thyroiditis, autoimmune hepatitis, inflammatory bowel disease, rheumatoid arthritis, and dermatitis herpetiformis. For the non-responders, it's also a spectrum, ranges from the poor compliance to having overlapping disorders, to having refractory sprue or refractory celiac, and also having complications. And for sure, the treatment will be tailored according which one of this spectrum do you have with your patients. When it comes to the gluten-free diet, we need to know that it have a lot of limitations, complex, costly, have a lot of nutritional deficiencies, have a social impact and psychological impact, and also some persons still having residual symptoms, even they are strictly following the gluten-free diet. The limitation of the gluten-free diet make the need for pharmacological therapy is an important unmet need in our practice. And the medications that are under development, according to the pathogenesis that we have showed in the first or 2 slides, it may be through following 3 strategies for the treatment. Firstly, to reduce the gluten antigenic load, maybe through genetically modified gluten, sequestrating agents or enzyme therapies, or something making the junctions of the mucosa more tight. We can go also for immune modulation by blocking the deamination of the gluten or blocking the gliadin presenting antigenic cells, or to block the cytokine production from the activated CT cells. And also we have some experience with the enteric release budesonide. The tolerance induction, a lot of medications with multiple companies working on this idea, but we need to know that none of these medications till the moment is approved by FDA, all of them in different stages in the clinical trials to be available in the market maybe soon. So my take-home message for this is you need to know the importance of screening for celiac disease in the patients with unexplained elevated liver enzymes. Celiac disease is connected to muscle D, and the people on gluten-free diet may have higher risk of having muscle D. We need to follow a holistic approach for the management of muscle D, celiac disease, and everything that we are working. We are not focusing on the disease, we are focusing on the person that we are treating, and we have a lot of limitations for gluten-free diet. That's why we need another pharmacological therapies, most of them still under development. Thank you all, and thank you from my team for helping with this.
Thanks a lot, dear Dr. Ahmed Cordie, for your elegant presentation. Any question from the ground or at the end of the day? Okay, at the end of the session.